Hello everyone. I hope you all doing great, and I just want to share this DKA management because I describe it shortly for Blab 2 sessions. However, just I thought I should discuss it in more details because it's very important topics, and regardless your levels, regard any exam, MRCP 1, 2, you will be encountered with DKA management, and it's really very important to know. So, diabetic ketoacidosis is a complication of type 1 diabetes, and it could be life-threatening if not treated promptly. So the diagnostic criteria as outlined by the Joint British Diabetes Societies are ketonemia 3 millimole per liter or significant ketonuria more than 2 cross on standard urine statistics. So most of the time, urine dipstick will be more handy and quicker than having the ketone in the blood. So because its nurses can do it for you straight away and give you the results. So 2 cross or more, it's significant. And blood glucose, it has to be more than 11 millimole per liters or non-diabetes mellitus. And most importantly, they should have acidosis. So venous pH less than 7.3 and or bicarbonate of less than 15 millimole. So to recap again, diagnostic criteria for DKA, ketonemia, more than 3 millimole per liters, or ketonuria more than 2 cross on standard urine dipstick, and blood glucose more than 11 or even non-diabetes, and acidosis, pH less than 7.3 and or bicarbonate of less than 15 millimole per liters. So any patient who has ketones in urine, you need to do venous blood gas, send it to the lab, and it will come back for you with everything written in the papers, pH, bicarbonate, potassium. Potassium also is very important in our treatment, so we need to know. I will speak about it in a minute. So this papers I took from the current hospital I work for, which I found it very useful and I use it to treat my patients. So the principle of management, as you know, is the fluid, insulin, and potassium chloride. So in terms of fluids, if blood glucose more than 13 millimole per liters, we're going to give 0.9 normal saline. And if the blood glucose of 13 millimole or less, we're going to give 5% dextrose. Remember this, forget about the sodium, because normally in the majority, if not all the patient, the sodium will be normal or low. So it's unlikely to have a high sodium with high blood glucose, because normally, as you know, hyperglycemic can cause pseudo hyponatremia. So most likely the sodium will be within the normal range and sometimes could be low. So just remember, if blood glucose more than 13 millimole, we're going to give 0.9% normal saline. And if blood glucose 13 millimole or less, millimole per liter, of course, or less, we're going to give 5% dextrose. In terms of the volume, it's always 1 liters, and in terms of the infusion rate, it's going to be the first liters in the first hour, the second liter in the second 2 hours, and the third liter is going to be run over 4 hours, and the fourth liters over 8 hours. So it's just, as you can see, is we have the same volume every time, but we double the infusion rates. The first liter we're gonna run it over 1 hour. The second liter we're gonna run it slower. the slower infusion rate is going to be over 2 hours, and the third liters over 4 hours, and the fourth liters over 8 hours, and the fifth liters over 12 hours if needed. So in terms of insulin treatments, it depends on the capillary blood glucose, and we need to set the serum pump with 0.9% saline, 50 ml, and soluble insulin, fast acting, 50 units. So it will be like 50 units of fast acting insulin into 50 ml of saline. So like we have 1 unit in each ml. So make it easy for the nurses to set the serum pump. And in terms of the capillary blood glucose, if it is less than 4, so obviously the patient has hyperglycemia, and hyperglycemia is treated with, we normally treat hyperglycemia with 10% dextrose. If the patient has capillary blood glucose of 4 to 6.9, we give 2 units, 7 to 11.9, we give 3 units, 12 to 14.9, we give 4 units, 15 to 19.9, we give 5 units, and more than 20, we give 6 units. Right, so the good news is you don't need to remember all this. So will be written, like some hospitals they have papers, and some hospitals they use it in their system, like EBR. So when you prescribe it, even it will be in the prescription, so the nurses they know when to prescribe and what dose should. So it's not that difficult. And in terms of potassium, if the serum potassium less than 3.5, we give 40 millimole per liters of potassium chloride. And if the serum potassium is normal, which is 3.5 to 5.4, we give 20 millimole per liters from the potassium chloride. And if the potassium is high, obviously we don't give anything. Right, so just to remember again, we have to give 20 millimole per liters if the serum potassium normal, and initially will be normal. And then after you giving dextrose or normal saline with glucose, so the potassium will start to go intracellularly, so the serum potassium will drop, so you may need to give high dose. If it drops to less than 3.5, give 40 millimole, but most of the time the patient will stay still in the normal range, 3.5 to 5.4, so we will always going to give with each liters of saline, we're going to give 20 millimole per liter from the potassium chloride. Well, so if our potassium within the normal range, so we can just check every 6 hours, but if the potassium is abnormal, either way, low or high, so we're gonna check more frequently, like every 2 hours. So sodium bicarbonate, please forget about that. It should be in ITU and senior levels, so I'm not gonna discuss about it. So that's all. So this is all about the management of DKA, and this is just different hospital protocols. So I guess I sort of should show you the differences. You may find different hospitals with different things from the one I showed you earlier. And this is actually what I used to use in my country, and I found it as well at in the Oxford clinical medicine book. So it's the differences in terms of the type of infusion. So we're gonna always give 0.9 saline, 1 liters throughout. Like we're not gonna, so it has to be 0.9 saline as far as the blood glucose more than 13. If it's less than 13 millimole, we can replace with 5% dextrose. And the insulin, it has to be fixed rate. So the insulin is going to be um, sorry for that. So what I was saying, so this one it's old guidelines, but still some hospitals are using these guidelines. So in terms of the insulin, we use fixed rate insulin, which is like 0.1 units per kg per hour. So if the patient, like for example, 60 kilograms, we're going to have 6 units per hour. Like if every hour, we're going to give 6 units, like fixed rate, and the fluid we're going to be 0.9 saline is the fluid of the choice, and we're going to give in the same infusion rate, the first liter over the first hour, and the second liter over 2 hours, and the third liter over 4 hours, and so on. So in terms of the potassium, also there is differences. So if the potassium normal, they're saying give 40 millimole. However, if you remember, in our previous hospital protocol is saying just give 20 millimole, which I feel is safer. So always stick to 20 millimole per liter if the potassium is normal. So that's all. Thank you so much, and enjoy study, and to see you at another time.